shift the workshop to the end of this session.
Okay.
Okay, so we can continue the program. We'll ask Dr. Bashan to show us how to use safely intraoperative neuromonitoring and what are instances that can be anticipated. Then we'll go for the interactive case discussions, and then we'll finish by the workshop. Dr. Bashan, the spine consultant, he is originally Egyptian and he has nationality from Sudan as well. Welcome, Dr. Bashan.
It's a great pleasure and honor to be with you here today. My talk is about intraoperative neuromonitoring changes in spinal deformity surgery. What do we need to know as spine surgeons? As you know, that multimodal intraoperative neuromonitoring is the standard of care during spinal deformity surgeries. Still, when we get the alerts during the operation, many of the spine surgeons will be perplexed about the interpretation of the underlying cause and what is the right course of action, causing unnecessary delays. My job today is to provide you with an evidence-based structured framework to standardize the response to intraoperative neuromonitoring changes. And by the end of this talk, hopefully all of us can differentiate the two patterns or the two alert patterns, whether it is perfusion-based deficit or direct spinal cord trauma. And after defining the alert cause, you should have a targeted treatment algorithm to address the problem. I will start with just a reminder about the applied neuroanatomy and the tracks that we rely on during we monitor the physiological activity during the operation. We have three tracts, two ascending tracts, the dorsal column that carries the ipsilateral light touch position and vibration sense, and we have the lateral spinothalamic tract that carries contralateral pain and temperature sensations. And we have the ascending tract, the lateral corticospinal tract that carries ipsilateral motor fibers to the anterior horn cells. As you can see, the arrangement of the fibers, we have the cervical fibers closer to the central gray matter. And that is why when we have a central cord syndrome, actually we have a pronounced serological deficit, more pronounced in the upper extremity when we compare it to the lower extremity. With respect to the blood supply, the main blood supply of the anterior two cells of the cord is actually the main blood supply of the anterior two cells of the cord is from the anterior spinal artery, which is formed at the foramen magnum by two descending branches from the intracranial portion of the vertebral artery, and it extends from the foramen magnum to the conus. Posteriorly, we have two posterior spinal arteries. They will supply the dorsal part of the cord. This long pipe that extends from the foramen magnum down to the conus, the anterior spinal artery, will need to receive additional supply from the spinal arteries, branches of the segmental artery. They will give anterior and posterior spinomedullary arteries. The most important one that arises from between T8 and L2, it is known as the artery of Adam-Q-Vatch. It is mainly 75% of the time arises between T or D8 and L2, and it is 80% of the time on the left side. Now, with respect to the different patterns of cord injuries that we need to know, I will cover them very quickly. We have the complete spinal cord injury, where you have affection, a bilateral affection of the corticospinal tract, spinothalamic tract, and the dorsal column. The central cord syndrome, again, we will have bilateral affections of the corticospinal, spinothalamic, and the dorsal column. With respect to the anterior cord syndrome, which affects the anterior two cells, and usually it occurs with perfusion problems, the affection will be just bilateral affection of the corticospinal tract and the spinothalamic tract. The dorsal column, we will have just affection of the dorsal tracts, the cuneate and gracile. The Brown-Séquard syndrome, we will have unilateral affection of the corticospinal tract ipsilateral affection of the corticospinal tract and the dorsal column, and contralateral affection of the spinothalamic tract. Now, if we would like to look at the correlation between the underlying cause and the different cause syndromes, we will have correlation, the main correlation between perfusion deficit patterns and the anterior spinal cord syndrome, where we have affection of the corticospinal tract and the spinothalamic tract. Other cord injuries or cord syndromes usually are caused by direct trauma. Now, during the surgery, we will have a neurophysiological neuromonitoring, and we will have a neurophysiology technician with us. The modalities that he will rely on to monitor the spinal cord activity is the somatosensory evoked potentials, and that will reflect the posterior cord function, mainly the dorsal columns, and we will have the motor evoked potentials, and that will reflect the anterior cord syndrome by monitoring the corticospinal tract function and indirectly the spinothalamic tract. And he will use the EMG to monitor the peripheral nerves. The motor evoked potentials usually reflect the anterior cord function, and it is a measure of spinal cord perfusion, and it requires total intravenous anesthesia. And we ask the neurophysiology technician to hit the button or to push the button in order to know about the motor evoked potentials. The key monitoring modality, it can be affected with direct trauma during the pedicle screw constructs, where you will have a unilateral drop in the motor evoked potentials. It can occur with traction if you are using excessive tractions, and if you have a large deformity and during your correction maneuvers. With respect to somatosensory evoked potentials, we monitor primarily the dorsal columns. It detects injuries to the posterior cord, and it is useful for laminectomies, intradural tumor resections, sublaminar wire insertion or passage of the sublaminar wires if you hit the posterior part of the cord, hook implant insertion. The neurophysiology monitor, the neurophysiology technician will tell you that there is a problem when he has a drop in the motor or the somatosensory evoked potential signal, at least 50% from the baseline signal. Now let us, with the knowledge that we have right now, to correlate things. Usually, the motor evoked potential is a reflection of the anterior cord, where we monitor the corticospinal tract. So we replace the corticospinal and the spinothalamic by what the neurophysiologist see on his screen is the motor evoked potentials. And what reflects the dorsal column is the somatosensory evoked potentials. And now we would like to correlate the different syndromes. Just pressing on the point, if you have a perfusion-based alert, it is usually bilateral loss of the motor evoked potential, while if you have a direct trauma alert, usually you have a unilateral loss of the motor evoked potential. And usually here you have a reduction in the mean arterial pressure, and usually you have here most of the time a normal mean arterial pressure. The common surgical triggers for perfusion-based LS is intraoperative excessive traction, deformity correction, or sometimes when you are closing your osteotomy. The common surgical trigger on the direct trauma alert, usually it is direct instrument contact or instrument slip. So again, if you have a complete cord or central cord syndrome, you have bilateral affection or a drop in the mean in the motor evoked potential and the somatosensory evoked potentials. If you have anterior cord syndrome, which is mainly a perfusion problem, you will have bilateral affection of the motor evoked potentials. If you have a posterior cord syndrome, you have affection in the somatosensory evoked potentials, and most of the time it is due to a direct trauma, and it's usually unilateral. If you have a Brown-Sequard syndrome, you will have ipsilateral affection of the motor evoked potentials and somatosensory evoked potentials. Okay, right now is the time for action. If you have a bilateral motor evoked potential and the neurophysiology is telling you that you have a bilateral drop in the motor evoked potentials, what shall you do? You have to think systemically and to address if there is a drop in the mean arterial blood pressure, you need to elevate the mean arterial blood pressure. If you have excessive loss of blood, you have to initiate blood transfusion. Temporarily, if you have excessive traction, you should reduce this traction. And if you have already did your correction, you either remove the rods, okay, and you should talk to your anesthetist if he can adjust the agents that he's giving to the patient to improve his blood pressure. A quick example here: after they insert the rod, they have a drop here, as you can see in the signal. Okay, here in the right side and one on the left side. They started to improve the blood pressure of the patient. With the mean arterial blood pressure was 60, they improved it to 90. On this side, the signal started to pick up. On this side, it didn't pick up. They needed at the end to remove the rod, and then the signal recovered. What if you have a unilateral motor evoked potential change? Most probably it is due to direct trauma. What you need is to identify and remove the offending agent and to allow time for recovery. That is the most important action. Example again, during decompression, they are using the Carison and they hit the dorsal part of the cord. They start to lose the signal here. He just stopped the decompression maneuver and he waited for some time. The signal again recovered. Patients, they do not need to recover the intraoperative signals to baseline to have normal neurological examination post-operatively. The observed signal in direct trauma, usually the improvement occur in 50% of the patients within 5 minutes, and in bilateral based in bilateral drops, usually it is slower and it takes more time. 35% recovery within 5 minutes, and some might take up to 60 minutes. So the primary, in summary, the most important thing when you have a signal, you have to identify the cause, whether it is a perfusion-based deficit or it is due to direct trauma. And accordingly, you should take an action. If it is a direct trauma, try to reverse the cause and to relieve the pressure. If it is due to ischemia, try to raise the mean arterial blood pressure. Consider giving blood and and do the correction. And talk to your anesthetist. Manage clinical endpoints. Recognize that a full return to a baseline signal is not required for normal post-operative neurological outcome. And at last, maintain post-operative vigilance for patients with significant perfusion-based alerts. Maintain diligent post-operative monitoring of blood pressure and close follow-up of spinal cord function. Thank you very much.
Thank you, Dr. Ahmed, for the presentation. Questions? Dr. Yasser.
شكرا دكتور احمد، الف شكر. هو بس انا عايز اقول ان الانترا اوبراتيف مونيتورنج بتعتمد اعتماد كبير جدا على الاوبريتور بتاع الماشين، لان انا فاكر يعني اول ما ابتديت الموضوع ده كان في عيان عنده سيرفايكال سبونديلوتيك مايلوباثي، وهو كان بيقرا كتير وقال لي انا عايز الانترا اوبراتيف مونيتورنج. كل ما اعمل اي حاجه اللي قاعد على الجهاز يقول لي وقف وقف وقف، انا ما بعملش حاجه غريبه. فانا عايز اقول بس ان الاوبريتور ده مهم جدا، لان هو ممكن يخلي الجراح فيري وري. في تشينجز ممكن انت حضرتك تقول انها اكسبتد زي ما انت قلت دلوقتي.
Yes, it should drop at least 50% from the baseline.
فمش
exactly.
مش كل حاجه انا اوقف الجراح اقول له لا وقف او ريفايز او دي نقطه يعني كنت عايز بس اوضح فيها ان الاوبريتور ده لازم انا لما يعني اجيب واحد بتاع IOM انقي واحد فيري اكسبرت، لانه بدل ما هيفيدني هيعمل لي توتر رهيب في العمليه.
I have a comment about Dr. Joseph too before you go to the workshop. The issue of pedicle screw insertion. All of us would like to do fixation and instrumentation for scoliosis, but with time I found a very good conclusion. It's the issue of 3D reconstruction in your brain about the direction and what I say to my fellows. It is the issue of a good learning curve. And one of the issues that I would like to mention, using the linky pedicle. It is very important, and it's very important, and don't worry if you go laterally. Take care not to go excessively medial, and if you go lateral, don't worry, it is more safer than to go medial and injure the spinal cord. So at the beginning of your career, go smoothly with the techniques as Dr. Joseph mentioned, and try not to go aggressively medial to avoid insult, which might be a disaster. Thank you.
Dr. Amr.
Just have two comments on the alerts of neuromonitoring. First, direct trauma can still cause bilateral loss of signals, depending on the severity of the trauma. And also, it is not necessarily an instrument that slips and hits the cord. Sometimes when you are doing an osteotomy and you're closing your osteotomy, a spike or a slight translation at the osteotomy site can compress the cord and cause a significant loss of the signals. Second point is that the tolerance of the cord for recovery after signal loss decrease after every alert. So after the first alert, it can take up to 5 minutes to recover. After the second alert, it can take up to 1 hour to recover. After the third alert, it may not recover at all. So be careful. Be careful when you have the first alert not to have a second alert.
شكرا دكتور عمرو على الكومنتس. في حد عاوز يسأل حاجة؟ Any questions?